Today we'll be discussing about how do we collect the data properly and how do we make tables out of it. So I think the best way to do that is with the example. So what we are going to do is we are going to discuss about this particular study, which is a retrospective study where we are going to find out the incidence of post-cataract surgery Descemet's membrane detachment and the outcomes of air descemetopexy. Now, all these terms are new for a lot of people, so we'll quickly go through the basics. So cornea has got 6 layers now, and the most important part of this Descemet's membrane endothelium complex is to keep the cornea in a dehydrated state. Now, when the cornea is dehydrated, it is clear, so optically clear, so that light rays can pass through. Now, what happens during surgery is inadvertently, sometimes this Descemet's membrane gets stripped out from the underlying stroma. So what happens, the stroma is being exposed to the aqueous humor, and this aqueous humor will hydrate the cornea, and this causes corneal haziness. So what happens when there is a Descemet's membrane detachment is, post-operatively, the cornea appears somewhat like this. This is called striate keratopathy. So this is one of the complications of cataract surgery. Now, when we take an optical section, we can see that detached Descemet's membrane is here, right? So this is called the Descemet's membrane detachment. And we can identify this via imaging also, where we can do an anterior segment OCT, and we can see the detached Descemet's membrane from the underlying stroma. So now there are various ways of treating this particular condition. One thing we can observe for spontaneous reattachment, but it takes a very, very long time. Sometimes it does not, in most cases, it does not attach by itself. The other thing that they have suggested is we can put a suture, but a suture through a hazy cornea is very difficult. So the best way to do is to give a tamponade. We just put an air bubble inside the anterior chamber. We put an air bubble inside the anterior chamber, and this air bubble has got a buoyancy effect. It is going to push the Descemet's membrane into the underlying stroma. So this is called the air descemetopexy. See, we have put the air bubble inside, and post-operatively we can see the cornea is very clear, and clearance happen quickly within the next 1 week. And we see the anterior segment OCT image. We see there is no residual Descemet's membrane detachment. So this DMD can also be classified into 3 types: mild, moderate, and severe. Clinically, in the slit lamp itself, we can do the classification. Usually for mild, we do not give any treatment. For moderate and severe, which includes 25 to 50% or more than 50% of the corneal involvement, in these cases, we attempt an air descemetopexy. Now, with this basis, we want to know how successful air descemetopexy is. Okay. So this is our research question. We want to see what is the success rate and what are the complications of air descemetopexy. Now, first step is how do you define the success? Okay, so over to you now. Just please answer me. How do you define success of this particular treatment? Anybody want to try? Come on, who's the mic? You have the mic with you. Sunil. How do you say air descemetopexy is successful or not?
Post-operative clear corneas.
Yes, first one, there is clear cornea. Why does the cornea clear? The Descemet's membrane is getting attached. So first thing, reattachment of the Descemet's membrane. So next, any other chance? So what happens when the cornea clears?
The visual acuity improves.
Vision improves. That would be the functional outcome. Okay. So these are the 2 methods by which you can measure the success rate. Okay. So that is the anatomical outcome is the attachment of the Descemet's membrane. Functional outcome is the improvement in the visual acuity. So based on this, we want to define the objectives of this particular study. This side. So the first objective would be to study the anatomical reattachment of the Descemet's membrane onto the underlying stroma. And the second objective is to see how much the visual acuity improves after descemetopexy. So apart from this, we are going to see our in-house Descemet's membrane detachment. That is, we do a lot of cataract surgeries, and some significant people develop this Descemet's membrane detachment. So therefore, we'll also be able to identify the rates of occurrence of visually significant Descemet's membrane detachment in different types of cataract surgery. And since we are doing an intervention, there are always chances of more complications that are happening. So that also we need to analyze. So when we discuss about any procedure, we also have to discuss about the cons of that particular procedure. So that is, we have to analyze the complications of adult hematopaxy. So these are the major objectives of our study. So for these major objectives, we need to collect the data. Okay. So now these are the specific same objectives. And what do you think are the data that is required to answer these objectives? So again, anybody want to try? People online can also try. So for the first objective, what do you think should be the data which we need to have from the case sheets? Come on, who's trying? What, Sudha?
On the first post-operative day, we will look for the
Correct. First post-operative day, that is after cataract
After
surgery,
cataract.
we see how much decimal membrane detachment is there. Then
Then
after
to what
deci-
extent it's there?
Yeah, correct. So it's a severity of the decimal membrane detachment, whether it's mild, moderate, or severe. That is one. Then after
How,
decimetopexy,
how it's affecting the visual acuity of the, I mean.
no, that would be the second objective. Okay,
first.
for the first objective. So grading of decimal membrane detachment and the extent we are identifying.
Okay.
And then after decimetopexy, we are looking at corneal clarity and reattachment of the decimal membrane. Whether any residual decimal membrane detachment is there, or if the corneal haziness is still persistent. So that would answer the first objective. Okay, grading and corneal clarity. So second objective, fairly simple. We want to see the functional outcome. So what do you want to see? What are the data that is required for this?
It's first is visual acuity.
Visual acuity. Visual acuity before decimetopexy and visual
After
acuity after decimetopexy. And we see whether there is any improvement or not. Okay. Okay, that's a simple one. And third one, you want to find out the rates of occurrence of DMD in ECC, SICS, and phacoemulsification. For starters, these are the three types of cataract surgery that we normally do. Okay. So now you want to find out the incidence. What is the numerator? What is the denominator?
How many surgeries we are doing?
Total one numerator. What is the numerator first?
Total number of DMDs.
Total number of DMDs in ECC divided by
total number of ECC.
Total number of ECC. So these are the data that you need. So from the case sheet, you need to take out what is the type of cataract surgery that is being done for that particular patient. And from the electronic records, we need to take out total number of ECCE, SICS, or phacoemulsification done during the entire study period. And that will give you the incidence of that particular entity. And finally, we want to assess the complications. So from the cases, you see whether there are any complications or nil complications, and list out all the complications which are possible by ardesimetopexy. Okay. So only are these data sufficient, or do you need more information? What other information do you want? So these are very basic data that you have taken from the case sheets. Apart from this, what other information do you think is needed from the case records? Come on. Yes, very good. First one, patient demography. So you want to tell whether decimal membrane detachment is more common in older people or younger people, right? That is one. Whether outcome of decimetopexy is better in older people or younger people. For this, you need the basic demographic information. Okay, so that is one. Then next, what else? So all those are covered under demography. Okay, anyways, socioeconomic study might not influence decimal membrane detachment outcome. So you don't need that. Then correct, wonderful. So before that I'll come to next. We also want to see the expertise of the surgeon. Okay, so expertise also, obviously we know trainees will have more complications than the experts. So now you want to say it is significant or not. So how do you say?
One surgeon.
So among trainees and among consultants, you want to compare. So what should be the numerator? Number of DMD in trainees by total number of cases by trainees. That is important. We don't put the total cases. We have to put total number of DMD among trainees divided by the total number of surgeries performed by trainees. you will get 1% there. And then you compare it with the total number of DMDs and consultants divided by the total number of surgeries and consultants. Now you then analyze these two data and see whether there is any significant difference or not. Okay. Then the type of cataract. Okay. So sometimes what they say is when there is a large cataract, you tend to make a large incision. So there is more chance of Descemet's membrane getting detached. So that's also one thing that you want to find out. So what we can do is we can find out total number of DMD in mature cataract divided by total number of mature cataracts operated on, and we can compare with the immature cataracts, right? So this is one thing. Then as you told, preoperative risk factors. So this is why literature search is again very important. So literature, what it says is when there is a corneal opacity or a corneal gutte, the chances of Descemet's membrane detachment is more. So but we need to find out how different it is. So what we can do, what do you think would be the numerator? So consider corneal gutte is a risk factor. So
So number of corneas with gutte having Descemet's membrane detachment
yes,
divided by total number of corneas with gutte, which
which
underwent the
have
surgery.
underwent cataract
Cataract
surgery.
surgery.
Yes, correct. And we compare it to the total number of DMDs that has happened, and we see whether this difference is any significant or not. Okay. So then we look into what do you think is next? What are the other information that you want to collect from the case records?
Sir, intraocular pressure.
Okay. So generally when there is an intraoperative complication, we tend to do a lot of manipulation. We tend to leave a lot of instruments inside, and this can strip the Descemet's membrane. Okay. So for starters, again, posterocapsular rent is one of the major complications of cataract surgery. So you want to see, so tell me again, what do you think? Anybody else want to try? No. For this intraoperative complication, what do you think would be the numerator and the denominator? How do you say Descemet's membrane detachment is more common when there is a PCR and less common when there is when it is uncomplicated? Yes, divided by. Yes, correct. Okay, so that would be the one thing. The other one would be to compare it with uncomplicated cataract surgery. Total number of DMD in uncomplicated cataract surgery divided by the total number of uncomplicated surgeries. Okay, so again, next we'll go to any other information that you need from the case records. Okay, systemic history we have to get definitely. Then yeah, that's what we've discussed. Preoperative risk factors are there, no? So there are a lot of preoperative risk factors, and we have to analyze all those. For example, shallow anterior chamber is a risk factor for Descemet's membrane detachment. So we have to see whether patients had a primary angle closure suspect before cataract surgery. So those are all preoperative risk factors. Then what else? Yes, correct. So which particular step this Descemet's membrane detachment happened? But the problem is this is a retrospective study. So most of the times this case record do not have intraoperative Descemet's membrane detachment. They are mostly diagnosed sometimes postoperatively, sometimes even intraoperatively. So this data cannot be taken from all the case records. But when we do a prospective study, we'll be able to get this information, which step the DMD happened. Okay, then. What else? Then grading of DMD we already discussed. Then the intraocular pressure is necessary because post-operatively there can be an IOP spike. So we want to see whether, because we are injecting air, right? So we are putting in more volume into the eye. So that can cause an intraocular pressure rise. So we want to see whether there is a significant IOP rise after air decimetopexy. Then what is the site of origin of DMD? So we are putting multiple ports. So there is because the tunnel is longer, there is a possibility that DM can origin more from the tunnel than from the side port. But then we'll have to see from our study whether there is any predisposition to one particular site or it's equally distributed between all the sites. Then this is very important. What is the interval between cataract surgery and Descemet's membrane detachment? I'll discuss about this later when we have the table. And then finally, we'll see what is whether there is any residual DMD or if there is a need for any reintervention. Generally, what we do is air decimetopexy is a very minor procedure. We just have to inject air into the antechamber under the Descemet's membrane. Failure of this means we'll have to do an endothelial transplantation, which becomes a major surgery. So what we do is we usually repeat air decimetopexy twice before we proceed with endothelial transplantation. So generally, when we do such studies, we need to have specific time points. We cannot compare one patient at the end of 2 weeks with another patient at the end of 3 years. So obviously, the cornea would have cleared by that time. So there has to be some standardization. So for this study, we have standardized it as pre-intervention and at 1 month. So pre-intervention means immediately after cataract surgery, before decimetopexy. 1 month is 1 month after air decimetopexy. And we'll see how much, what do we see? How much the anatomical outcome is, how much the functional outcome is. So these two are the things we are going to assess. So the Excel sheet somewhat looks like this. It's actually quite big. We'll see. So generally, first we'll have the serial number. Then we have the patient demographic details. So date of cataract surgery. When was the cataract surgery done? What was the type? Whether it was a hard cataract, mature or immature cataract. What was the type of surgery that was done? So then whether pre-existing ocular pathology was there. Then we have the pre-intervention details. Mainly, we want to see visual acuity and the extent of the Descemet's membrane detachment. Then when was the intervention done? What was the gap between the intervention and the cataract surgery? And then at the 1 month post-operative period, we have the post-intervention details. For example, this patient had a visual acuity of 6/60. So after surgery, it has improved to 6/12. Whereas this patient had 2/60 with a severe Descemet's membrane detachment, which was persistent. The same severe Descemet's membrane detachment was still present, necessitating repeat decimetopexy or an endothelial transplantation later on. So from this Excel sheet, now how do you make the tables? Okay, so that's what we are going to see now. So what is our first table? What is our first outcome? Anatomical outcome, right? We want to see Descemet's membrane is attached or not. So this would be the first table. So we have anatomical outcome as success or failure. Success we have already defined. Success means anatomical attachment of the Descemet's membrane, and post-operatively cornea has to be clear and there should be no residual Descemet's membrane detachment. So we see after the first intervention, first decimetopexy, 71% of the people did not have they had anatomical success. Okay, and 32 people did not have. So out of these 32, 15 people underwent a reintervention and 9 people had successful reattachment. So in all, we see 80% of the population had a successful outcome. That is, their Descemet's membrane got attached after cataract surgery, after decimetopexy. Okay, so these people did not require an endothelial transplantation. So that's what we want to describe from this first table. So next, we'll go on to the functional outcome. Okay, so what do you want to see through the functional outcome? Improvement in the visual acuity. So firstly, we'll put a small table like this. We'll look at the final visual outcome. So at the end of 1 month after surgery, how many of them had improvement in their vision? So that's what we are going to see. So we'll see here, but we are seeing only those patients in whom Descemet's membrane was attached. So if the Descemet's membrane was not attached, obviously corneal edema is going to be persistent and they are not going to have good vision. Okay, so among those in whom the Descemet's membrane was attached, among the 87 people, 75% of them had visual acuity of 6/18 or better. Okay, but what happens is this table does not describe whether visual acuity has improved after decimetopexy or not. Right? You're understanding that point? Okay, this only gives you the final visual acuity. It does not compare with the pre-decimetopexy visual acuity. Now, if you have to incorporate that, the table becomes very large and complex. Okay, so that's why we need to depict such complex tables in the form of figures. Now, this is called the box and whisker plot. It will show you how much the visual acuity has improved. So before we go on to the details of this, we first will understand what is logMAR. Generally, visual acuity is measured in Snellens in meters. Okay, that's what we normally do in India. So 6.6 is normal vision. So when you see the logmar value, it is 0.00. Okay, 0 in logmar means good visual acuity, and 660 means 1. So as the visual acuity decreases, the logmar value increases. So that's what you need to understand here. So generally, when you want to calculate the mean visual acuity, it's very difficult to do with the Snellen's fraction in meters. So, but it's much easier to do with the logmar scale. Okay. And at this point, we also have to understand the various measures of central tendency here. There are three. One is mean, median, and the mode. Okay. So we'll have a short example here. I have given you 11 patients whose visual acuity are arranged in ascending or descending order. So now, any idea what the median of this group is? So median is the central value after arranging the distribution in the ascending or the descending order. Okay. So median would be 618 here because we have 5 values on either side. Okay. So then what do you think is the mode? So mode is the most repeatable value. So here we have 3 groups of 624, which is the highest, and therefore that is called the mode. Okay. So we have 3: arithmetic mean, median, and the mode. So now we'll come back to the box and whisker plot here. So box and whisker plot gives you the median. Okay. So now forget about these 3 charts. We'll just look into this particular chart here. So what happens, consider there are 100 people with visual acuity that we are analyzing. Okay. So we arrange all the 100 people in ascending or descending order. Okay. So this would be the 0th percentile, and this would be the 100th percentile. So the gap between these two would be denoted by the box and whiskers. So this one is called the box, and the two on either side are called the whiskers. Now, after arranging all these in ascending or descending order, we'll get the middle value. So that would be the 50th percentile. So what is the 50th percentile called? Median. You're understanding that? So the median visual acuity here before decimetopexy in patients with moderate Descemet's membrane detachment is 0.5 logmar, which is 618. Okay. So understanding this box and whisker now. Now after decimetopexy, we are going to see. Before that, how do we get the box? So the box refers to the space between the 25th and the 75th percentile. Okay. If you arrange 100 values in descending order, so gap between the 25th and 75th will be given by the box, and this is called the interquartile range, IQR. Okay. So now after decimetopexy, what happens is we see the visual acuity has improved, right? Visual acuity is closer to the bottom. 0 is good visual acuity. So 1.5 is bad, poor visual acuity. So we see there is improvement, definite improvement in the median of the visual acuity. Now here we have to see what is this one. There is one extra dot on top. So this is called the outlier. So what they do is generally when they draw the box and the whiskers, this whiskers extend up to 1.5 times the interquartile range. Any value which are in the extremes are depicted as outliers because they don't usually draw the whiskers to the end. So any value which is just too far on either side, they are called as outliers. This is called the outlier here. So this is with regards to moderate Descemet's membrane detachment, and we are now able to understand that there has been an improvement in visual acuity, and same way for the severe Descemet's membrane detachment. So again, preoperatively there has been like the median is again 618, and post-operatively we see it has significantly improved. Now we don't see the middle line, right? Where did it go? Any idea? So here what happens is the middle line is on the 25th percentile itself, because 25th and the 50th percentile are almost the same. Why does that happen? Can you think and tell quickly? Yes, there are so many 618s that from 25th to 50th percentile, all values are 618s. Okay. So we have a large number of values in 618. Therefore, the 25th and the 50th percentile are the same. Whereas when we go to the 75th percentile, it goes much higher. You're able to follow? Any doubts in this? No, right? And the same thing happens in severe Descemet's membrane detachment. But definitely what we can see from this graph with just a glance is there is definite improvement in the visual acuity after desmetopexy. Okay. Next, we go on to the third table. I mean, third major objective. We are going to find out the incidence of Descemet's membrane detachment after cataract surgery. So now there are three main types of the cataract surgery: ECC, SICS, and phaco. These are the total number of surgeries that we have done during the study period, and these are the total number of Descemet's membrane detachments. So we get, obviously, how did we get this? How did we get 0.26? 4 by 1559 into 100. Okay, so that's how we get the percentage. Now, based on this percentage, which do you think causes more DM detachment? Quickly. ECC causes more DMD than SICS than phacoemulsification. But can we tell like that? So one thing is we have to do some statistical analysis and find out if this difference is significant or not. So that's why we get the p-value here. Okay. So now we got the p-value as 0.106 when we compared ECCE and small incision cataract surgery. Now, what does that mean? Though the percentage of DMD in ECC is more than SICS, it is not statistically significant. So you cannot tell that ECC causes more DMD than SICS. Okay. So what should be the statement be? There is no statistical significant difference between the incidence of DMD in SICS or ECC. So that would be your statistical statement. Okay. And when we analyze this ECC and SICS, ECC with phacoemulsification, we got the p-value as 0.005 and less than 0.0001. So which is less than 0.05. Any p-value which is less than 0.05 would be considered to be statistically significant. So now what should be your statement? What should your statement be? Incidence of lower. So phacoemulsification causes less Descemet's membrane detachment compared to ECCE and SICS. So this statement you can make, but the same statement in SICS or ECC you cannot make. Okay, that's what we want to understand with the p-values here. Okay. Next, the fourth major objective is to list out all the complications that can happen after air descemetopexy. So the most important and the most common one would be a persistent Descemet's membrane detachment. So that has got the maximum numbers. Around 20% of them had a persistent Descemet's membrane detachment. And there is a possibility that this is a very thin flap which can get detached. So that can cause a corneal decompensation. And again, we are putting air into the antechamber. There is a possibility that this air can go under the iris and push the iris forwards, and leading to oppositional angle closure. So there are around 17% of the people had this oppositional angle closure. And when we overinflate the antechamber with air, it can cause a pupillary block. And because we are doing another intervention, there are higher chances of uveitis and fibrinous membrane formation. So these are the common complications that we expect, but we see which is most common and list out in a table. There is no comparative group here. So what we need to do is just list out the total number of patients, and in the brackets we can give the percentage. Generally, when you give percentages like these, a single decimal is sufficient. We don't have to be too much precise in giving two decimals. It just complicates the data. And then finally, we'll also understand the timing of intervention and the success rate. So now that's why a proper literature search is again important. So there are two schools of thought. One, they say we have to intervene early. The other group, they say we have to intervene late. So now why they say early is because as the time progresses, they say the Descemet's membrane becomes less pliable and does not get attached back to the stroma. The other group says when we intervene on the first post-operative day, that we do not properly visualize the Descemet's membrane because the cornea is very hazy and chances of failure are more. So now we want to see which is better. So that's why we have to analyze from our data. Okay. So here we'll see with moderate decimal membrane detachment first. There are 67 people who had moderate decimal membrane detachment. And after decimatopexy, we see 51 of them had a successful attachment. And 16% of them had a persistent decimal membrane detachment. Now, among these 67 people, 53 underwent surgery within the first 14 days. And 14 of them underwent surgery after 14 days. And when we look at this, we see 28% of these people who underwent surgery, decimatopexy early, had a persistent decimal membrane detachment, whereas this percentage was only 7% when intervened late. So what do you understand from this particular statement? What can you comment? What do you want to say? Mike.
The incidence of Descemet's membrane detachment was lesser
No, not incidence. We are talking about successful outcome.
The outcome of the surgery was much better if the intervention was carried out later.
Correct. So this is what you want to tell. But what happens when we look at we look at the p-value. So what is the p-value here? 0.13. So though it appears as if late intervention is better, it is not statistically significant. So what should the statement be now? What should be your statistical statement?
So the incidence of DMD,
It's the outcome of decimatopexy.
outcome of decimatopexy is higher, is better with delayed intervention with p-value,
But it is not statistically
which is
significant.
not statistically significant.
Okay.
Yes, sir.
So that's what you want to tell.
Yes, sir. Sam, yes, sir. Because inadequate science. Yes.
So
Yes,
the
sir.
other thing is, see, the numbers are grossly different. No, there are
Yes, sir.
53 in one group and 14 in the other group. So ideally, it should be similar between two groups so that you can do a proper comparison. Okay. So the same thing happens for severe decimal membrane detachment also. See, among the 33 people who underwent early intervention, 15 had a persistent DMD, whereas only 1 out of the 9 who underwent late intervention had a persistent DMD. So again, but this p-value is not statistically significant. So again, you say though it appears as if the late intervention is better, it was not statistically significant. Okay, you're able to understand this. And finally, I told you we are going to look at the site of origin of DMD. But what this is a problem because this is a retrospective data. So there were a lot of unknowns here. So okay, so this is the main incision. This is through the side port, and here it was not properly documented. So therefore, if you have to do a prospective study, you can have a column in the proforma and get the information from the operating surgeon where the site of origin of the decimal membrane detachment is. So in that case, we can have the proper data. Here it looks as if both groups are similar, equally distributed between the tunnel and the side port. So for basic information like this, we can use bar graphs to depict the data like this. So this is the basics with regards to our study on decimal membrane detachment. So I guess if you work more on you can analyze your protocol and see any other information that you can get out of that paper, you can include it in the proforma itself so that data doesn't go missing. Okay.